This is Dr. Bernstein with your July 2018 teleseminar. Before we begin, I want to first warn you, as I usually do, that the answers I give are not hard answers. They're approximate answers because I haven't examined the questioner, I haven't gotten a complete history, and the purpose of this teleseminar and my videos is to educate the general group of listeners. So I might give you some interesting information that could be of general value, but may not be the exact answer to the question that is asked. That's the way it goes. We do have a special subject this month. There was an announcement in the journal Nature Medicine about research conducted recently or reported recently by the University of Alabama in Birmingham. They experimented with a hypertension drug, verapamil, that's been around for probably more than 30 years, a pretty benign drug. They've been experimenting with it for the prevention of type 1 diabetes. And according to their report, in many of the patients who were tested, now I say many, I think something like 30 or 40 patients were tested, and only about half of them were on the product. The others received a placebo. So it was not many patients. And my recollection is that it may have only been 13 patients who experienced a halt to the progression of new onset diabetes, type 1 diabetes. So this treatment supposedly protects the beta cells from burnout. The word that they used is called apoptosis, which means self-destruction. Now, why do I take the trouble or the time to discuss this particular experiment when there are so many other so-called cures being reported every month or two? The reason is because I've used medications like this for other purposes, and they are very benign. I've not seen adverse effects from them. This verapamil is in a class of drugs called calcium channel blockers. I've used for 30 years a calcium channel blocker called nifedipine for many of my patients, not for the initial indication, which is hypertension, but for a variety of other situations, such as insect bites, allergic reactions, even for singers to extend their upper range. I use nifedipine when I do my seminars because I have an IgA deficiency that affects the mucous membranes, that includes the larynx and vocal cords and so on. And the verapamil prevents or inhibits inflammation of these structures. So I'm not surprised I use the nifedipine, but verapamil acts in a very similar manner. So there is a good possibility that this may be of value. The important thing is that it probably is virtually without adverse effects. I find that the nifedipine will not significantly lower blood pressure in people who already have low blood pressure, although it will dramatically lower blood pressure in people who are hypertensive. That's basically the story. Whether this will totally prevent further progression of type 1 diabetes once the injury to beta cells begins, we don't know for sure. whether it would pay to give this product to high-risk individuals, people, let's say siblings of a type 1 diabetic. So these trials yet have to be performed, but as I said before, it's a benign drug, and if it does the job, I wouldn't expect much in the way of adverse effects. Now on to our first question. 36-year-old female for type 1 diabetic, 32 years, A1C, last A1C was 4.6. 10 days before my period, I experienced unpredictable and elevated blood sugar levels, plus insulin resistance. My doctors refused to prescribe Glucophage to help with this issue. What can I say to get them to prescribe Glucophage? Well, why would this lady want Glucophage? Probably because I've recommended it for women who have blood sugar problems or blood sugar unpredictability at around the time of their periods. Usually it's a week before their periods, and I've been prescribing Glucophage for a long time for this purpose because I've seen it work. Now, because Glucophage is meant for type 2 diabetics to lower insulin resistance, apparently these physicians are afraid to try it on a type 1 diabetic. It's very common that I see physicians and pharmacists fearful of prescribing a drug intended for type 2, for type 1s, or prescribing a type 1 drug like insulin for type 2s. This is not logical. I think that their doctors are very fearful of lawsuits, so if they do anything that's unconventional, they're afraid that if something goes wrong, they might get sued. So one thing you could do is tell your doctors that you won't sue them if they prescribe Glucophage. Another thing you might do is to you'd have to do a search, a Google search of the internet for articles showing the use of metformin or Glucophage for non-diabetics and for type 1 diabetics. There probably are a number of such articles around. In fact, Glucophage has been used in non-diabetics to treat certain cancers and was for many years recommended, maybe not officially, as a means of extending life. It was considered the fountain of youth when it first became available. So there's a lot written about Glucophage for non-diabetics and so on. That's one possibility. The other possibility is to be sure to use Glucophage XR. Your doctors may be fearful of the side effects, the most significant of which is diarrhea, and it's less likely to occur with the Glucophage XR, the timed release. Another option is to find a kindly family practice physician. According to the communications I've received from listeners, family practice physicians seem to be more open-minded to unique approaches to the treatment of diabetes and not as fearful of violations of the guidelines. So how would you find a family practice physician? You'd ask your neighbors if they have a family practice physician who's kindly, whom they like, etc. 6 years old, type 1 diabetic. Read your book and follow your diet. He doesn't say the guidelines. Switched from Lantus to Basaglar, which is another name for Lantus by another manufacturer, because of insurance. Seems to cover her from 8 p.m. to 8 a.m., then stops working. Please help. Well, this person clearly is not following the regimen in my book. He's following just the diet. And if he followed the regimen, it would say that any long-acting insulin that's available today must be used twice daily. So you have to approximately cut the dose in half and take one dose on arising and one dose at bedtime. And as I've pointed out before, sometimes even the evening dose may not last adequately into the morning because of the dawn phenomenon. So people such as myself have to take an evening dose at bedtime, which for me is, let's say, 10 p.m., and another dose around 4 a.m. So I'm not taking one when I go to sleep and one on arising, but I'm taking them something like 6 hours apart. But it does require 2 doses. All of these long-acting insulins require 2 doses. Now, if he's read my book carefully, he knows that I don't recommend Lantus, but I prefer Levemir, or from my lectures, more recent than the book, I prefer Tresiba, Tresiba. My 10-year-old diagnosed type 1 2 months ago. Currently, she has constant blood sugar levels of between 76 and 104 milligrams per deciliter, which is a reasonably narrow range. For a child, it's a little on the high side. Non-diabetic children mostly are in the 70s. Is the fact that she does not receive insulin a problem? Well, the only problem is that her blood sugars are slightly elevated, and most doctors wouldn't worry about it. They're waiting for beta cell burnout before they prescribe insulin. We do know from the research that high blood sugars are toxic to beta cells. Now, is a blood sugar of 104 milligrams per deciliter toxic to beta cells? I don't know. But I would play it safe. So I would try to get that 104 down a little. It might take something like a half unit of Tresiba once a day to cover the time of the day when the blood sugars go, let's say, above 85. That's all I can think of. And is it a significant problem? I just don't know. If it were me, if I were the patient, or this were my child, I would try to keep the blood sugars really normal for a child. After reading your diabetes solution book, I have tightened up my control. Starting 3 months ago, I had retinal photography, which revealed a significant increase in exudate. I am now concerned that I've tightened up too quickly. Should I ease back and try to improve things more gradually? Well, the only thing I know of with regard to rapid reduction of blood sugars and diabetic retinopathy has to do with serum levels of IGF-1. It was published some time ago, maybe 10 years ago, that if a type 1 diabetic has elevated serum levels of IGF-1, that's insulin-like growth factor number 1, and already has retinopathy, that if you rapidly normalize blood sugars, the retinopathy will get worse. Now, I don't know what your IGF-1 is, but you might want to have it tested. And what you're describing when you talk about exudate is falls into the general term of retinopathy. Are pickles okay to eat? The doctors say I am between type 1 and 2. The tail of my pancreas was removed 3 years ago, and I am on 4 insulin shots a day, but I crave pickles all the time. Well, pickles are relatively benign, but not totally benign. That is, if you were to eat, let's say, 6 big pickles, and you're a diabetic, there's a good chance that your blood sugar will go up. If you ate a half of a pickle and you're a large person, it might not budge at all. If you ate a half of a big pickle and you're a little child, a type 1 diabetic, your blood sugar might go up. So pickles are have small effect on blood sugars. As those who have read my book know, that anything that occupies mass, occupies bulk, will distend the gut and can raise blood sugar in a type 1 diabetic. This person still has part of a pancreas, so she's between type 1 and type 2. I'd say that you want to cut down the constant eating of the pickles. How to do that? There are a number of ways. We discuss food cravings in my book, and there are some tips on what you might do. Can autoimmune attack in a child with type 1 be reversed with food or supplements? I doubt it very much. I think that you should read my book, and if the child has diabetes, you better start controlling blood sugars. Can my husband go on insulin for a short time to lose weight and then go back to metformin, glimepiride, and Victoza after the weight loss safely? Well, going on to insulin, especially if it's used to cover carbohydrate, is going to gain weight. The metformin lowers insulin resistance and facilitates weight loss. It also sometimes lowers appetite and thereby facilitates weight loss. The glimepiride, which is a sulfonylurea, increases insulin secretion, is more likely to cause weight gain, and has been associated with increased heart disease risk. So going on insulin per se is not likely to cause weight loss. I think that you and or your husband really should learn a lot more about diabetes and the medications used to treat it, and therefore should read my book, Diabetes Solution. Can the keto diet reverse or cure type 1 diabetes in children? First of all, there are probably many, many keto diets. All kinds of practitioners, including people who claim magic, create their own keto diets and call it a keto diet. And for as far as I'm concerned, I don't like most of the diets that are sold as keto diets. I use a low carbohydrate diet, which is high in protein and tends to approximate what our pre-agriculture ancestors ate. And it doesn't reverse diabetes, it just makes it much easier to treat than the usual diets that most people eat, which are high in carbohydrate. Non-diabetic, my question is about fasting. I like to fast 1 day a week, and sometimes I fast for 3 days. When I fast for 3 days, my glucose gets into the low 60s, and once it went down to 51. Is that a problem? Well, it's a problem if you operate machinery, drive a motor car or a boat, or an airplane, because at these low levels, your cognition is impaired, your reaction time is impaired, your mobility is impaired. You can get into trouble, especially if you're that low for hours. So probably it's not, what you're doing is not wise. You might be better off fasting for one day if you feel like fasting, or maybe 2 days that are spaced apart, but 3 days in a row is, in your case, asking for trouble. Do you have a special authorization form along with what you say that you send to insurance companies when prescribing Glucophage instead of generic? Glucophage is the brand name for metformin. As most of the listeners know, we found that when generic metformin first became available, people switched. Their blood sugars went way up. TRICARE doesn't okay the brand, so I wanted to try what you submit. The prior authorization form is made available by the insurance company. So if your insurance company is turning you down, you have the right to request a prior authorization form, and you can fill it out and submit it, or your doctor can fill it out and submit it, and it will ask questions like, have you tried the generic Glucophage, and what were the consequences, etc. You could say that you had an allergic reaction, or you got diarrhea, or something like that. If the doctor fills it out, it might have more influence, but the doctors might not want to spend the time filling these out. You can fill it out yourselves. Now, will the insurance company act on it? That's another story. I cannot predict that. Can you provide any advice on how to elevate my testosterone levels without sacrificing the progress I've made in lowering my blood sugars? Or will I continue to suffer from low testosterone due to my carb restrictions? Well, I don't think I've ever encountered anybody who developed low serum testosterone levels because of carbohydrate restriction. There have been reports of low testosterone in people with type 2 diabetes, and my recollection is that it was thought that was coincidence, that the two tended to be inherited together, but certainly low carbohydrate should not lower testosterone. And I wonder whether you've really had your free testosterone measured. You could also have your testosterone binding globulin measured. And even wiser, you should see a reproductive endocrinologist who can work you up to see what's going on. I would like to know what you think about the recent publication in Nature about reduction in glucose levels with the BCG vaccine. Is this something to be hopeful for? Well, in that report, the report that you're referring to, the A1C that was achieved was 6.65, which is an average blood sugar of 166, which is double normal. Now, if the authors claim to have cured diabetes, based on their own numbers, they didn't cure diabetes. they achieved blood sugars that were double normal. The use of BCG to try to treat type 2 diabetes and or type 1 diabetes publications have come out in the past from one laboratory, and when other laboratories try to duplicate the results, they were unable to. The report of other laboratories came out in the journal Science many years ago, maybe it was 10 years ago. Now, I certainly don't think that an A1C of 6.65 is a cure for diabetes. Have you examined and analyzed Dr. Stephen Grundy's plant paradox diet? What would you endorse and what would you caution against? I don't know Stephen Grundy. I don't know his plant paradox diet, but I suspect that if there's something for sale, if this doctor is selling something, and if he's making extreme claims, that it's probably to be avoided. Take a look at his website, see what he's selling. I might be wrong, he might be selling nothing. He might be just sending you out recipes and charging you for them, I don't know. But getting magical results occurs pretty rarely in this day and age. 20 years old, diagnosed with diabetic gastroparesis. Despite eating only once a day, I still get very bad nausea and feeling of lightness in my chest. I've been diabetic for 6 years, and my A1C is 7. Now, right off the bat, this person is doing just the opposite of what someone with gastroparesis should be doing. Those of you who listen to my teleseminars know what it is. If you don't know what it is, read my book, Diabetes Solution. With gastroparesis, stomach emptying becomes erratic, unpredictable, and as a rule, slowed down considerably. So you should be eating small meals, preferably liquid meals, and eating all your meals as one meal per day is the worst thing you could do. You're loading your stomach with something it can't handle. So read my book and the chapter on gastroparesis. It's important enough that I have a whole chapter devoted to this. Male, 36 years of age, grossly underweight, with type 2 diabetes for 9 years, takes glimepiride, which is a sulfonylurea. I need to gain weight and finding it very difficult. I've increased my calorie intake and blood sugars are around 250. I do resistance training now instead of walking. I'm strictly vegetarian. Well, this person is asking for trouble. A blood sugar of 250 is about 3 times normal. This person is on is a vegetarian, so is probably eating a lot of carbohydrate and not getting enough protein. So this person probably has protein malnutrition. You can exercise, but you're not going to build muscle if you don't eat enough protein. Muscle is made out of protein. So if you insist on being a vegetarian, I'd suggest that you nevertheless start eating eggs, cheese, and have normal blood sugars. Remember that people with high blood sugars convert their own muscle mass to glucose. It's called gluconeogenesis. And you should read my book to learn how to control your blood sugars. That's about all I can say. So you'd have to eat protein foods and vegetables. Even the so-called high-protein vegetables have very little protein in them compared to the amount of carbohydrate that they have. At the moment, I find I need to give myself 4 units of Humalog at 2 a.m. during my sleep to have a blood sugar of about 90 milligrams per deciliter when I arise. This person takes Lantus insulin at 7 a.m. and 7 p.m. What can be done to not inject at 2 a.m. during the night? Well, first of all, it'll be nice to know when this person goes to sleep. If he goes to sleep at midnight, he should try injecting at 7 a.m. and midnight. If he goes to sleep at 10 p.m., he should try 7 a.m. and 10 p.m. He may find that, like me, he has to inject at 10 p.m. and 4 a.m. But first I would try many alternates. And one alternate is to switch to Tresiba insulin instead of the Lantus. The Tresiba is much longer acting than Lantus. So you might try, let's say you go to bed at 10 p.m., you try taking Tresiba at 10 p.m. and when you arise in the morning. And again, read my book. After a recent high 8.3 A1C, which is an average blood sugar of about, let's see, 252, I began to follow your diet recommendations with some success. My random blood sugars, by the way, here again is a person who's following the diet recommendations, but not the whole system for controlling blood sugars. My random blood sugars have improved. However, I noticed a large spike when I weightlift over 50. When I weightlift, the spike is 50 milligrams per deciliter or more. Today it pushed me up to 171. My doctor will not prescribe insulin. Is there an alternate way to address the exercise-induced spikes? Am I better off to forego the weight training in general, or should I accept the spikes? Well, it is, if the doctor refuses to prescribe insulin, one can say, try a beta blocker. I have had a number of patients whose blood sugars go up when they do physical exercise. And when I give them a beta blocker like rapid-acting beta blocker like propranolol, say an hour before the exercise, sometimes for many people it stops the blood sugar rise. So that's a possibility. The other option is to get a kindly family practice doctor who will be more rational in treating your diabetes. Of course, your doctor may have a good reason for not prescribing insulin, but I'd suggest that you read my book and don't just look at the diet parts, look at everything in the book and see if you could figure out what kinds of medications you need to control your blood sugars. And then if your doctor will not give you those medications, and there are many for type 2 diabetes, you can find yourself perhaps another doctor. But first see if your doctor will prescribe something other than insulin. I'm leafing through a lot of questions that are covered in the book, because as a rule, I try not to answer questions that are already covered by the book. How do you recommend safely controlling blood sugar during intense endurance activities, long-distance running, backpacking, mountain climbing, instead of dropping too low during these activities? I typically keep my blood sugar very high. Well, first of all, I'd recommend that you get a continuous glucose monitor so that you get warnings if you get too low. Second, I suggest that you get frequent blood sugars along the way. Well, if your monitor is really accurate, in theory, you don't need frequent blood sugars, but I would still say that you should check them yourself, perhaps hourly. You should carry with you liquid glucose. Here's what I use. And if you can't afford to pay for the liquid glucose, you could make it yourself. I believe we have a video that instructs on how to make your own liquid glucose cheaply. That's basically it. I have a number of patients who are marathon runners, triathlon people, and they get frequent blood sugars, and they carry liquid glucose. You could even make your own liquid glucose and carry it in one of these sippy bottles. And people who have read my book know how much of the glucose how much their blood sugar will go up per teaspoon of liquid glucose. And there are ways of getting a plastic pipette that will dispense exactly a teaspoon or a half teaspoon. My doctor agreed to let me try Glucophage XR instead of glimepiride, which is a sulfonylurea, that he had recommended originally glimepiride. After taking 500 milligrams twice daily, which is a very small dose, and checking sugar daily, it didn't do anything to lower it. Well, I would expect that if you're taking the lowest dose. If you're taking the time-release version, the XR, you typically need about 2,000 milligrams a day. And if you're taking the rapid-acting glucophage to cover meals, you need about 2,500 milligrams per day, which is 5 times as much as you're getting. He wants me to try the glimepiride, but I'm just not comfortable doing so with its side effects and possibility of burning up beta cells, burning up whatever beta cells I have left. My C-peptide is elevated. Do you think on my next visit it would be appropriate to ask him if insulin would be the next step? Well, I would first try a reasonable dose of glucophage, and then you could consider insulin. But first, read my book, Diabetes Solution, because you want to know how to use insulin. And most doctors don't know how. I have heavy callus growth on my feet. It is very serious and equally vexing. I do not know what to do about this problem. Well, something is either pressing or rubbing against one or more spots on your foot. And I assume you wear shoes, and it's likely that it's the shoe that's pressing or rubbing. And there's also a good chance that if you explore the uppers of the shoe, the top of the shoe, the sides of the shoe, etc., with your finger, you'll find that over the callus, the shoe has been stretched. There's a bump in the shoe. And that's because your shoe is smaller than your foot. And that's why it's rubbing your foot and causing a callus. So if you have only one callus or two calluses and they're on the upper or the side of the shoe, you can buy a shoe stretcher. You can see them, you can Google shoe stretcher or go to an online store or a shoemaker. Shoemakers have shoe stretchers. And you can stretch the shoe right over the place where the callus is so that it's no longer rubbed. And most calluses will disappear if the shoe's been adequately stretched. Now, of course, there could be some people who have a callus that's half an inch thick. That poses yet another problem and might require intervention by a podiatrist to reduce the size of the callus. However, when I ran the wound care clinic at a major metropolitan hospital, I found that in the course of, over the period of 30 years, the people who had diabetics who had amputations of toes, feet, or legs, all cited one instance of what happened to start the salami surgery of cutting that ended up with them losing a toe, foot, or leg. And in every case, it was a podiatrist trying to remove a small callus. So that you have to be wary of. The treatment of calluses is to get the pressure off the shoe or reduce the pressure from the shoe. I have been on your program successfully for several years. I recently manifested gout symptoms, and my uric acid hovers around 6.8, which is very close to the 7 over the top uric acid level. Do you have any recommendations for persons with gout following your recommendations? Well, first of all, you should go to a rheumatologist who specializes in treating gout. And there are different forms of gout. The crystals that could appear in your joints can be of different types. In your case, it's probably uric acid crystals because your uric acid is high normal, but there are people who have hydroxyapatite crystals that have nothing to do with diet. So see a rheumatologist. There are medications, and if you have high serum uric acid levels, there are certain foods to be avoided, like organ meats, and again, the rheumatologist will tell you about that. I have had a wound between 4th and 5th toes at the base for nearly 4 months, and it is not healing. About the size of a pencil eraser, about a quarter-inch deep. Well, a quarter-inch deep is pretty deep. I have neuropathy in both feet from gout medicine. Healthy weight. Exercise 4 times a week. I have tried placing wedges between toes to allow air circulation. Betadine to my area with no progress. What do you suggest? Well, first of all, I can't tell if this person is diabetic or not. And if he is diabetic, a non-healing wound could relate to elevated blood sugars. So if you're diabetic, we want normal blood sugars. Next thing is not to use betadine because it destroys the macrophages that heal the wound. You probably need to indeed put something between the 2 toes that are rubbing, but you should also widen the shoes so that there be room between the 2 toes to put something. So you may need a larger shoe size. You may need sandals where you can adjust the width with a Velcro strap. You may need a cast boot. You might want to be wise to go to a wound care center where they can prescribe the right footwear that would enable you to put something between your two toes. There are a variety of products available on the market for putting between the toes, including some gel products, but you have to leave room in your shoes. If you put something between the toes and then squeeze the toes together, that product's not going to be doing any good. One other thing, since the wound is there, you have to put something on it. You could put possibly gentian violet, but this should be under the direction of a physician who specializes in infectious disease. There are certain antibiotic ointments that are broad spectrum. If it's not already infected, then probably the gentian violet would be of value, but you have to get the pressure off. And that certainly means wider shoes. I've had type 1 diabetes for over 40 years and follow your recommended low-carb diet. I take 2 split doses of Tresiba daily. My problem is with dawn phenomenon. Some days I experience profound rise in glucose from 6 a.m. to 10 a.m., goes from 80 to 160, and other days I do not experience such rise. Do you have any thoughts about what can be done about that? Well, my first thought is that the fact that it varies from day to day, something may be going on. It might be something inflammatory. My first thought would be to take some timed-release Glucophage XR, and I would take it at bedtime. And it's not likely to cause dramatic reductions in blood sugar, but it does have the possibility of preventing a rise. So that's worth trying. Then you might take your Tresiba at 3 o'clock in the morning, which is 3 hours before you arise, and that might do the job. The trouble is that's interfering with your sleep. One other possibility would be to assume that something inflammatory is going on and asking your doctor to work you up for an inflammatory disorder. And if he can't find anything, you might try some anti-inflammatory products like curcumin and see whether they have any effect. In your book, you mentioned aspartame and also diet sodas as being acceptable. Are those opinions of yours still current? Yes. There's one thing that still confuses me about dealing with the dawn phenomenon. If I take 1/2 unit of regular Novolin R to correct for my rising blood sugar upon awakening, because I usually don't eat until later, mid-morning or noon, does that mean I have to wait the full 5 hours for the action of the insulin to be completed before I can inject again and eat brunch? Well, this fellow or woman has not carefully read my book. Because in the book I say you do not correct a blood sugar elevation with rapid-acting insulin until you wait until the prior shot of rapid-acting insulin is finished. And taking a shot for your brunch is not correcting an elevated blood sugar. If you're taking the right dose for the brunch, it's a washout. You should come away with the same blood sugar after the brunch as before the brunch. I've had a total thyroidectomy, and now my blood sugar is out of control. A1C 8.5. I complain about being excessively tired, gaining weight, high blood sugars, poor concentration, forgetfulness. Do these conditions have an influence on my diabetes control, or am I just whining? Well, if you had a thyroidectomy, you should have thyroid hormone replacement. And that usually is with T4. Some people use both T3 and T4. So all of this, including the weight gain, relates to slow metabolism. The tiredness, the forgetfulness, poor concentration, all of these are symptoms of hypothyroidism. Now, clearly your diabetes also needs treatment, or you wouldn't have such a high A1C. So I suggest that you see a thyroid specialist, and that you also read my book about the treatment of diabetes. I have hypothyroidism and am taking levothyroxine. That's what I was just mentioning. Will my cholesterol improve as my A1C goes down on a ketogenic diet? I am concerned about my heart health. Well, first of all, cholesterol, as listeners know, is no longer a measure of heart health. I've discussed all of the other indices that seem to be predictive of heart health. But low thyroid does cause higher risk of heart disease, as does high blood sugar. Now, will a ketogenic diet help your blood sugar? I don't know, because I don't know what a ketogenic diet means. If you want a diet that I know, a low carbohydrate diet that does help blood sugar, you could read my book, Diabetes Solution. But if you have diabetes, you may also need many medications in addition to just the diet. I'm still finding many questions that are answered in my book. Finally found a page that I'm going to answer. I'm trying to figure out my insulin requirements, but the formulas in the book are confusing because my weight is so much lower than 140 pounds. Well, right off the bat, the book tells the reader that if you weigh more or less than 140 pounds, you take the ratio of your weight to the 140 and you adjust the dose accordingly. So if you weighed 280 pounds, you might take twice as much as I recommend for 140. Or if you weighed 70 pounds, you might take half as much. I'm a petite woman, 59 years old, and weigh 97 pounds. And I'm making some C-peptide. What math equation should I use to determine the correct fast-acting insulin requirements to cover meals based upon my weight? Well, this is another mistake. This lady, somehow, either my book is not clear or she's not reading it right. The amount of insulin for meals is not based on weight. The amount of basal insulin is based on weight. The amount of insulin for meals is based on food. And in the book, we say that a theoretical start would be less than 1 unit of insulin for every 8 grams of carbohydrate. And I tell you how much less. I forgot what it said in the book. Could be 10% or 20% less than 1 unit for every 8 grams of carbo, and 1 unit 1/2 unit for every ounce of protein. But again, I reduce it to play on the low side at the start. So it will be less than 1/2 unit for every ounce, might be 1/4 unit for every ounce of protein. Then if you see your blood sugars go up, you raise the dose. So it's all there in the book, and you don't have to adjust your food insulin for your weight. You should read what it says. I inject insulin and my body is still able to make its own. Will my pancreas stop making its own insulin? No, but if by injecting insulin you normalize your blood sugar, you prevent the destruction of your beta cells by high blood sugars, because it's been shown that high blood sugars are toxic to beta cells. So you can preserve, hopefully, or maybe preserve your own ability to make insulin by normalizing your blood sugars. And if it takes injected insulin to normalize your blood sugars, that's what you should be doing. In the package insert for Tresiba, it states not recommended for pediatric patients requiring less than 5 units of Tresiba. Do you know why you need to take more than 5 units of Tresiba? I know, because that's what it takes to keep my fasting blood sugars normal around the clock. I take about 6 units twice a day. Now, it has to do with the total mass of my body tissues that have insulin receptors, and that includes fat, muscle, and recently discovered even the brain. So maybe I have a big brain, and that's why I need more than 5 units a day. I have type 1 diabetes. I take 3 units of Tresiba in the morning and 3 units at bedtime. It seems to me working, except for a few elevated overnight blood sugars due to a mild gastroparesis at dinner time. Would it be better to take 6 units once a day, and if so, why? When? I don't think it would be better. And if you read my book, you'll find many recommendations for the gastroparesis at dinner time, including putting some of your food from dinner at lunchtime, because digestion tends to be slower at dinner time. It seems to me that my legs hurt more when my blood sugar is lower and less when I let myself go and eat some chocolate. Yeah, elevated blood sugars can rapidly increase neuropathy. So your feet or legs, you apparently have neuropathy. Your feet or legs are numb or partially numb, and usually when neuropathy heals thanks to normal blood sugar, the numb feet become very painful. In fact, one podiatrist who is diabetic described it as lancinating pain, very severe pain, during the 2 or 3 months that it took for the numbness in his feet to go away. So if you want to make your feet really numb and not feel anything, have high blood sugars, and of course that will accelerate your demise and make it more likely that you'll injure your feet and possibly have problems as a result of that. I'm almost 2 years vegan due to high cholesterol and family history of heart disease and diabetes. I gain lots of weight and worry about prediabetes. Have hard time finding what to eat. My protein is based on tofu, vegetables, legumes. Well, this person doesn't ask a question. I would suggest that he read my book, and the game plan to reduce the risk of heart disease would be to have normal blood sugars and also to do some of the exercises that we recommend in the book if the exercises are not hazardous. If you already have heart disease, some of the exercises I recommend could be dangerous. Well, I think we'll do one more question. My daughter was diagnosed a couple of months ago. She is 3 years old. Are there any tweaks, tips, or additional readings or advice needed for implementing the plan with an active 3-year-old? This person apparently has read my book. First of all, I'd recommend that you subscribe to the web page of Type 1 Grit. It's a Facebook page, GRIT. You'll see what other people with type 1 diabetes, including parents of children with type 1 diabetes, are doing. I also strongly recommend that you bring with you injectable Tygan when you travel, because if she ends up vomiting when you're traveling, you don't want to have her end up in a strange hospital. One other little tip is a treat that you could work into our meal plan, and that is heavy cream with chopped ice and Da Vinci cookie dough syrup mixed in with it. You might want to dilute it with water, or she might want it straight, but kids seem to like it even better than ice cream, and it has very little effect on blood sugar. You might find that she might need a quarter of a unit of insulin to cover it, but that's trial and error to find out. Well, that's it for tonight. We'll see you again in 1 month on Wednesday, the 29th of August. Thanks for listening, and good luck.